Good afternoon. Welcome to the first meeting of the Interim Joint Committee on Families and Children. I hereby call this the first meeting, and welcome for those who have missed us so much. We're glad you all are here today, and we're glad to get back in the business of talking about families and children. As a reminder, please silence all cell phones so they are not a disruption to any of the presenters that we have. Do any members have any special guests they would like to recognize? Representative Holloway?
Thank you. This is my daughter, Julie. She's 9 years old. And were you here for the last meeting, or was that Gemma? I think must have been her sister. I can't even keep them straight. But this is clearly her first committee meeting, and she loves coming up to Frankfort. This is her third trip, and I try to bring one of them every time I come, just to help out at home a little bit. So I'm thankful that I'm able to do that.
Welcome. We are so glad you are here with us today. You are the future of Kentucky, so we're glad you're learning about the important legislative issues. As you all know, when I chair meetings, I like to remind people the total number of children in out-of-home care with active placements. And as of June 1st, 2025, that was 8,641. So we still have a lot of work to do to get children in homes. DJ, if you'll please call the roll for the Senate and the House.
Senator Deneen. Senator Funky Fromeyer. Senator Girdler, Senator Herron, Senator Mays Bledsoe, Senator Meredith, Senator Mills,
Here.
Senator Webb, Senator Williams, Senator Wise, Representative Bojanowski, Representative Callaway,
Present.
Representative Kleins,
Here.
Representative Dietz, Representative Doan, Representative Duval,
Here.
Representative Elliott,
Here.
Representative Holloway,
Here.
Representative Mosier,
Here.
Representative Pollock, Representative Rayburn, Representative Riley, Representative Rorks,
Here.
Representative Stalker,
Present.
Representative Wilson, Co-Chair Carroll,
Here.
Co-Chair Heverin.
Here. Thank you, DJ. Our first presentation today will be the discussion for the Center for Courageous Kids. Mr. Roy and Ms. Cosby, can you please make your way to the testimony table? I had the opportunity to meet with their CEO during session, and I knew they would be a great fit for the agenda during the interim, sharing the good work that they do. As a reminder, today each group will have 15 minutes to present. I will have my timer on. I know that everyone likes to have a concise agenda during the interim. We don't want a lot of long meetings. So if you'll introduce yourself for the record, and then you can go ahead and get started with your presentation. And make sure your green light's on.
Good afternoon. Hi, my name is Brian Roy. I'm the Vice President of Development for the Center for Courageous Kids. And with me is Emily Cosby, the Marketing Communications Manager. And just a thank you to start off with welcome us here. We're very proud and love what we do, and we're excited to share it all with you today.
Thank you.
All right, so we have been so eager to come into you guys today and share the magical moments of why we do what we do at the Center for Courageous Kids, but we need to set some context and talk about what we do first. So at the Center for Courageous Kids, we offer camp to children in Kentucky, to surrounding areas, other states, and other countries too, that is designed to support those living with lifelong illnesses and disabilities. We create a medically safe and inclusive environment for them, and we do it all free of charge. So that's the best part. Campers are never charged to attend the Center for Courageous Kids. And it all started with the generosity of one woman and her dream, and that's our founder, Miss Betty. Miss Betty was from Scottsville, Kentucky, where the Center for Courageous Kids is located. She had a son who was diagnosed with cancer in childhood. He lived to early adulthood and passed away. And she's also a big fan of NASCAR and spent some time in Florida and was introduced to a camp very similar to how the Center for Courageous Kids operates. And so it planted a seed in her mind of wishing and hoping that there was a place her child could have participated in camp, a childhood rite of passage in her area. And so she created that. She established the Center for Courageous Kids in 2004. She gave 168 acres of her father's farmland and the startup funds to make sure that it could be constructed. And we opened our gates in 2008. So a little bit about what makes us unique is that we offer 2 specialized programs. We operate year-round. In the fall and spring, we offer family weekend retreats for the entire family. The diagnosed child comes with mom and dad, siblings that live in the home, and they participate in camp together Friday through Sunday. In the summertime, we offer independent week-long camp sessions where the diagnosed child comes independently from their family and they get a chance to experience camp alongside other campers going through very similar life situations as them with a similar diagnosis and similar challenges, so they can really bond over that. Since we opened in 2008, we have served over 43,000 campers from 46 states and 13 other countries. But it's important for us to let you guys know that 22,000 of those campers have come from Kentucky. 1,255 applications came from Kentucky in 2024 alone. And CCK has served 94 of Kentucky's 120 counties. And it's one of our biggest goals in the next few years to try to make sure that we reach recruitment from all 120 counties. With those 43,000 plus campers, we've served over 100 different diagnoses. So our medical team works diligently to make sure that no child is ever turned away based on their condition or diagnosis. So we want to make sure that camp can become a reality for every child. And the nurses that we have on staff will work with parents to find a camp session in our calendar that might be right for their child and safe for their child to attend. And then it's important to note one more time that our program is 100% donor funded and no one is ever charged to attend. Since day one, no one has ever been charged to attend. Now, I have a question for the room and just a show of hands. Who has attended summer camp before as a child? Who attended summer camp? Perfect. So lots of people in the room that you might have some memories from when you attended summer camp. You might remember a counselor that was important to you, or a friend that you made, or something fun that you tried for the first time. And what we know to be true is that parents who send their children to summer camp really want 3 things for their child. They want them to build confidence, they want them to gain independence, and they want them to meet a new best friend. And at CCK, we have developed a program that is intentionally able to do this, and this is how we do it. So of course, those of you who have been to summer camp, maybe sent your children to summer camp, you know it's fun. Camp is fun. And these 2 girls right here are about to jump in a canoe and have a blast. And they're gonna build a connection, a memory, and a friendship along the way. But camp's not just about fun. One thing that CCK does really well is takes it to the next level with our accessibility-focused and inclusive environment. So you've got a camper here, Peter, who he's center stage at stage night. He's facing a crowd of his peers and counselors that are ready to cheer him on with the song he's about to sing. And I think you can tell from the smile on his face that he's going to gain confidence as he exits that stage with the cheering going on behind him, and he's going to carry that moment with him forever. Then we have campers like Joey, who another area that we have at camp is our horseback riding. Joey lives with a physical disability, so he cannot walk on his own. But on horseback, he can get the sensation of walking on his own that he can't get doing anything else. There are lots of programs that can't serve Joey, but at the Center for Courageous Kids, we can. He gets to experience independence when he comes to CCK, because he's not told no, he's told yes when he is at camp. And then when you take all of those 3 points and add them together, you get a story like this camper Zion, who's been coming to camp since the youngest he could come at 5 years old on a family weekend retreat. He's come back summer after summer until he aged out at 17. And this is a picture of him in his U.S. wheelchair rugby team Paralympic photo. He was or is the youngest wheelchair rugby team member, and he returned from the 2024 Paralympics with a silver medal. And we're so happy to know that CCK has been a part of his journey. A lot of the confidence that he built, the friends he made, the community that he shares helped get him to where he is today, and we hope that for every camper that attends CCK. Up next, we'd like to show a video from one of our campers who attended in 2024, the summer of 2024. He's from Louisville, and this is an inside look at his story at CCK.
CCK has made that experience for me to where I can have fun with other peers, but also be safe, and to know that I'm not the only kid with this disability. CCK has helped me build my courage to enjoy the things that I love.
He gets to come here and he gets to do those things. He gets to do archery, fishing, horseback ride. He gets to do just all that.
I had made so many friends. Without making friends there, I wouldn't be able to go out and make friends all over different states.
He has had these opportunities that really have built him as a kid. CCK has afforded him the opportunity to see himself as a person who is able.
No matter what I'm born with, how old I am, the disability is a ability. And as long as I'm who I am, to me, abilities outweigh disabilities.
When I have him in these spaces like this, I know that he's going to take away something to launch him, to help me feel confident. Maybe parents with children that don't have disability, they don't think about that because they meet this milestone, that milestone, that milestone. But parents with disability, I know that's what we think about. What's the next milestone? What's elementary? What's middle school? What's high school? What's college? What's job? What's love? You send your kid out to CCK, you feel a little bit more hope. Okay, there are people who actually come and love them. So if there are people here who come to love them, those people exist beyond these walls. That's what I want families to know. You just send your kids here, you'll find hope.
To meet people with the same disability as me at this camp, I see a path of light. If people have the same disability as me, if they can do this, I can do this. When you donate your money to CCK, you are changing lives. Your money is going to a place where kids feel respected for who they are. They're finally being understood and having fun while being understood. CCK changes lives for the good.
A little picture from another time, a little picture of a place that we used to go, a word
Awesome. So with CCK, we look at how we're supported through 4 pillars. The first pillar is through donations. Financially always helps us. It's how we survive. It's how we thrive. Is through the gifts from everyone in Kentucky and throughout the nation. So 63% of our 2024 donors came from Kentucky. The second pillar of support is our volunteers. We're working with a bunch of universities, local organizations, local hospitals in the Kentucky area. A quick story. This is Josh, who's a nurse at Norton's Children's Hospital. He came with us this past week, and his job at this point was to follow around this young camper who needs oxygen not only when he's around camp, but also in the pool. So Josh, a nurse, was following him around. Additional piece to Josh is, Emily, you probably share this a little better. He met a camper he'd already known.
Yeah, so when he attended as a volunteer this summer, he met a camper that he was like, I took care of you in the cardiac ICU when you had your heart transplant at Norton Children's. And they didn't know that they were going to be at camp at the same time, but it was a beautiful meeting because that's one of the benefits of being able to work with medical institutions and have them be able to treat within the camp setting is they get a different view of their patients and their patients get a different view of them. So that connection was really cool to see this summer.
And then our third pillar is gifts in kind. We've been lucky to have a bunch of organizations. Fisher Contracting, which is out of Franklin, Kentucky, has built a couple of things recently for us. The campfire ring, which at some point was just a fire ring in a field, is now an amphitheater with a walkway. To the right is the boating and fishing pathway. That was not ADA accessible. They came in and they redid a road for us recently. Tens of thousands of dollars they've given to us. And then the fourth in support is spreading the word. So everyone in this room, everyone out there in YouTube land knows someone or has someone who's experiencing one of these disabilities or diagnoses. Come to camp, come visit camps, send them our way. And then the last piece we want to share today, which is what we're looking at for the future, is some capital projects that we're looking for some investment in. So our art barn, we want to take it to the next generation. So we currently have art, we have musical and woodworking and typical bracelet making. We're looking to bring in new technology. When we talk to kids, they want to be YouTubers and podcasters and they want to do videography work. And we want to bring that to them, not because we want them to do those jobs, but it's because that's where they're at. We want them to do those things with us so they gain independence, they grow, and they make their best friends. So we're looking at building a new art barn to include all those things. The second piece we're looking to do is build a medical lodge. Currently at camp, we can support 8 volunteers. And as we're growing, we're in the need of new healthcare partners, new nurses, new doctors. So we need some more adequate medical space for them. So to ask today, our Art Barn project is at a total of $2.5 million. We have ecstatic to have some matching support already. So a legislative ask would be at 1.5. That medical lodge project is at $2,875,000 with, again, some matching support at 1.125. So the request there would be $1,750,000. And we'd love support either for one, for both, but the total ask would be at 3.2. But again, thank you so much. We love what we do. It's a special place, and I think both of us feel we're stewards to this location that served a bunch of kids, and we'll continue to do that.
Thank you. Wow, what a blessing you all are to so many families in Kentucky and around the world, around the nation. I want to say take all my money. Thank you. I think I know I needed that as a way to start the interim, with the full heart and recognizing how special people are. And so thank you all for that. Thank you for the presentation. We'll go ahead and go for some questions. Representative Riley.
Thank you, Madam Chair. I really don't have any questions. I just got a few comments. I live about 25 miles from the campus. I've been on the campus several times. It's beautiful. You can just feel, there's just something you feel there when you're there about how much the people care and how those children are getting so much out of this. And I want to thank you for what you do for those young people. And it's a blessing to have in South Central Kentucky that we have that beautiful program that works for so many young people. So thank you for what you do.
Thank you.
Thank you.
Co-Chair Carroll.
Thank you, Madam Chair. And it was a pleasure meeting with you all earlier today. And we got to talk through quite a bit of the issues with the camp. And I wish I had known about this many years ago as in the organization that I lead, at least for 2 more days I'll be leading. There are lots of families that would benefit from that. And I'm going to carry this information back home and make sure that our community is aware of it. And I know some families are going to be pretty excited about this. Talk a little bit organizationally with the regulatory environment, things like that. What are the things that you all struggle with from year to year? I know financially that's always a struggle as a not-for-profit, but regulatory, those types of things, what are your struggles?
Yeah, so we just organizationally, we operate with about 30 full-time staff across all departments, from the people that take care of our grounds to the people that supervise, the medical safety at camp. And we run a lot of our program with the help of supplemental volunteer work. And we have full-time recruiters on staff that are going to local universities and medical institutions trying to get the word out. But I think just you sharing, Senator Carroll, about, I wish I'd known about this sooner. That's one of our biggest challenges, is having opportunities like this to share about the Center for Courageous Kids. We've been the best kept secret in South Central Kentucky, and we don't want to be a secret anymore. So I think just making sure that awareness is out there about our program, making sure that people know us far and wide, that it's an opportunity that is, as long as you can get to us, we want to serve you. But just awareness of our program is number one. And then I think just recruitment of staff and volunteers to make sure that we can serve our maximum number of campers.
Madam Chair, one more, please. Do you all fall under like the OIG's office? Do they come out and do regular audits as a licensed camp?
So we are connected and accredited through the American Camp Association, and we do receive visits and audits, so to speak, to make sure that we keep that accreditation. And then, of course, just the health department, making sure that our kitchens, our facility, and our pool facility are up to code, and clear the standards in that way.
Okay, very good. Thank you all for what you do.
Yes.
It's awesome.
Thank you.
Are there any more questions? Representative Mosher?
Thank you, Madam Chair, and thank you so much for your presentation. This is amazing. I love seeing this. I had some opportunities to volunteer at asthma camp when my kids were little. My husband's pulmonologist, kind of the same idea, normalizing, activity for kids and giving kids confidence when they have a medical condition. Mm-hmm. So the money that you are seeking to raise, will this allow you to serve more campers, or I'm looking through all of your numbers, and you serve a lot of campers every year. At any one time, how many campers do you have, and what will this money do to expand that?
At any one time, we're in our summer season right now. And so for a summer session, we can serve up to 128 kids per session. In the family weekend retreat season, we can serve between 30 to 34 families, just depending on the size of the family. So we can take families up to 8 people, and we can take families as small as 2 people. And how that fits in our facility is how many families we can take. So with the hope of these 2 asks that we've made, expanding and making sure that specifically the medical lodging will help grow our medical volunteer base. And once we have more room for medical volunteers, we'll have more room for traditional volunteers, because the housing we're currently using for medical volunteers can be used for that in the future. And then once we can secure more supervision, we'll be able to expand our camper base past that 128 campers in the summer.
Okay, thank you.
Yes.
Okay, thank you very much. I do want to say I was kindly invited. I don't know if I'll be able to make it this summer with the schedule, but if of course, it would be on your own time. Chief Floyd, I hope you're taking note of that I said that. It would be on your own time and time. But, what a great opportunity, especially if you're close by, to take the opportunity to go and visit. And so thank you all very much for your presentation today. We greatly appreciate it. Safe travels going back, and I hope it's a wonderful summer.
Thank you.
With lots of love.
Yes.
Thank you so much.
And we left you guys with a folder of some more takeaways, which has a few more pieces of information that we weren't able to present.
Awesome. Thank you all. Next up will be a discussion on adult protective services and state guardianship programs. Ms. Swain and Mr. Bryant, can you please make your way to the testimony table? Please introduce yourself for the record, and then you can go ahead and get started. Make sure that when you push your microphone that the green light is on.
Good afternoon. My name's Jessica Wayne. I'm the director for the Division of Guardianship.
And I'm Cliff Bryant. It shows green. Am I just not close enough? Oh, sorry. I wasn't looking at it correctly. My name is Cliff Bryant. I am an assistant director with the Division of Protection and Permanency inside of DCBS.
So we're going to start with guardianship today. So guardianship is governed by KRS 387.500 through 800. So that is for all guardianship, state, family, private guardianship, and then specifically to state guardianship, we are governed by KRS 210.290. I also listed the regulations in case you all are interested in looking into them, but that covers our referral process, our day-to-day activities, and our accounting provisions. So guardianship is a legal representation between the adult, the guardian, the adult guardian, and the individual. And so we call them individual. Unfortunately, statute still calls them ward, so I will be talking about individuals. A guardian is a court-appointed individual or person or entity that has the duty and the power to make personal and or financial decisions for the individual. For the state guardianship, that's when a family member or a private entity is not available or appropriate, and then the court appoints the state as an alternative. In Kentucky, that's done under the Cabinet for Health and Family Services and the Department for Community-Based Services. So here's a little information about the types of guardianship. So these start with a petition within the court. So someone, family, friend, a facility, a hospital, anyone can file a petition starting the process to determine an individual needs a guardian. And that starts through district court in all 120 counties. Usually it's the county where the person resides at. And that county and that judge will either do a trial by bench or by jury and determine if the person needs a guardian, conservator, neither, or maybe a little bit of both. And so that's the different types of guardianship. So if all your personal rights are removed, then you end up with a full guardian. If only partial rights are removed, you get a limited guardian. If all your financial rights are removed, you get a full conservator, and the same thing if you're a limited conservator, so partial. There is a part of the statute that allows for emergency appointments of guardians and conservators, and that is if someone cannot wait for a trial, which usually takes about 60 to 90 days. Under the regulation, this is kind of the process and criteria for the state to be appointed as the guardian or conservator for an individual. We need to ensure that we are the last resort and all other options have been exhausted before the state can be appointed. So here it goes into a little detail on what the definition of a disability. So it's really important to understand this is a legal disability, not a medical disability. Many people think just because you have Social Security disability that you are appropriate or will get a guardian, but it is very different. This is about inabilities to make decisions. So not so much your willingness to make a good decision, but your inability based on your disability and functional inabilities. For state guardianship, we accept adults, which is defined as anyone 18 years or older, but the statute allows for personal and family guardians to be appointed at 17. And this is really for those aging out youth that are 17 going on 18 to ensure that the guardianship is in place before they age out at 17. So just for your information on state guardianship, the majority of individuals that we serve come from these 4 diagnoses. So they have developmental intellectual disability. We have, out of our total as of June 1st of 4,645, we have 1,546 in the supported community living waiver, so in the SCL waiver. And then second to that is individuals in nursing homes or long-term care facilities, and we have about 1,460 in those facilities. So those 2 make up the majority of the individuals under state guardianship. But we also serve people with individuals with severe and persistent mental illness and those that have brain injuries and are in waivers. So we have 3 prongs to guardianship, I like to call, or 3 different branches. So there's the division of guardianship, which is the field services. So my staff operate in all 120 counties. We have 14 regional offices, and they're the ones that are going out and doing regular visits, attending meetings, making those medical decisions, approving residential placement, arranging transportation, those kind of things. And then we have 2 other branches. One's called the fiduciary branch, and the other is the benefits branch. And the benefits branch, they apply for any benefits. So if they are eligible for Social Security, VA benefits, food stamps, anything like Medicaid, Medicare, they apply for those on their behalf. And then our fiduciary branch, they actually are the ones that's managing the funds. They make sure that they're invested, they pay the bills, the rent, and take care of all the financial side. So our individuals, there's not any state funds or federal funds that operate to care for those individuals. They have to utilize the benefits that they're eligible for. So if they need to go into a nursing home, they need to be eligible for either private insurance or Medicaid to be able to pay for the cost of their living. Here's a little information on our trends. So currently, like I said, we have 4,645 individuals under guardianship. You don't see a lot of movement in that over the last 5 years, but I'll give you some information after this about why that is. We have currently 89 field workers throughout the state, so the average caseload is 52. We are working on trying to get that average down into the mid-40s, and so we do have we are increasing staffing, and we have started the hiring process on additional staff. So this is the last 5 years of the new cases we get versus individuals that have passed away or individuals that have resigned. So you can see we have increased a little and kind of steadied out. Last year we had 801 new individuals appointed under guardianship for conservatorship or guardianship. We had 421 individuals that passed away, and then 314, those are the exciting, those are people that resigned. So they either got their rights back or somebody else was identified that could come forward and become the guardian of those individuals. Many of that is family members. And so some of our initiatives, we do have, like I said, a goal of reaching the caseload of 45 per worker. And so we have recently hired and are in the process of hiring another 10 positions, and so that goal can be achieved. We are encouraging our staff and assisting individuals in getting their rights restored. So yearly, we review the individual to determine, are they capable of getting some or any of their rights restored? And a lot of times it's a slow process. So getting maybe 1 or 2 rights restored, the right to make some of their decisions or handle some of their finances, and then slowly progress so that they can prove to the court that they're capable of that. And then we're promoting consistency on the referral process and who's appropriate for the state to be appointed. So we do a lot of education with community partners and with the court system, and just to ensure that those referrals are appropriate.
And now we have Adult Protective Services, otherwise known as APS. The primary focus of APS that most people know of is the investigative arm of it, so conducting those investigations into abuse, neglect, and exploitation. We also provide social services that are really aimed at preventing and remedying that maltreatment that it's occurring. And we also have the emergency protective services option that is designed for individuals that have possibly diminished capacity to make decisions and that they need some additional help through the court system to get their health and welfare needs met. So specifically, we use this definition of an adult. So it is anyone that is 18 or older that has a mental or a physical dysfunction that impairs their abilities to manage their resources, carry out activities of daily living, or protect themselves from abuse, neglect, or exploitation, or hazardous situations without assistance from others. And then the last piece is the may be in need of protective services. So we look at all four of those pieces to say that this person meets that definition of adult for us to do an investigation into potential maltreatment. We do have pathways to services, so our referrals are screened through the hotline. It is the same hotline that's used for child protective services as well. This hotline will screen for anything that's an investigation or what's called an assessment, which we'll talk about here in a second. APS workers will investigate those reports that meet acceptance criteria and make a determination of a finding. And then also we have voluntary services that can be requested through our general adult services. And with general adult services, we do have specific individuals that qualify for these services. So it's a person that is 65 or older who does not have that mental or physical dysfunction, but they are being abused, neglected, or exploited by a family member, a household member, or a caretaker. Another one is an individual 18 or older that has a mental or physical dysfunction, but they are not currently being abused, neglected, or exploited, and they just are requesting services for a vast majority of reasons, like maybe they need assistance with finding alternate housing, different things like that. 18 years or age or older, and they're an alleged victim of domestic violence and they're requesting services. So again, we don't do investigations into domestic violence, but we do offer services to them if they seek out our APS. And lastly, we will assist a young adult that is transitioning from out-of-home care within the past 12 months, and they're requesting services for self-sufficiency. And so with these general adult services, what we're looking at is those it's completely voluntary, so they need to be requesting these services or directing someone else to request on their behalf. It is designed to assist them in attaining and functioning at their highest level of self-sufficiency and autonomy, and to maintain in the least restrictive environment of their choice. So this is our APS caseload average over the past 5 years. As you see, COVID dropped our caseloads down quite a bit because the referrals did slow down a little bit, but then slowly they went back up, and now we're seeing a little bit of a decline. We still hope to get below that 30 average caseload to make sure that our adults are getting the attention that they deserve. And this is an average of our referrals that have met criteria over the past 5 years. You can see that those numbers are going down. These numbers are specifically related to the number of calls that we receive or intakes that come in through our hotline or faxes, emails, anything like that. And the substantiated number, although it does look lower, it is also per adult. So it is not a unique intake, it is a unique adult. So you could be substantiated on several times over the course of a year, but it would only capture this number once for you. So with initiatives, we are currently working on self-neglect represents about 41% of all of the referrals that we meet. Self-neglect is an issue that is seen across the entire United States, that there is a focus on whether or not that this needs to be investigated versus assessed. These are individuals that may be experiencing medical concerns, mental health concerns, that they just need that extra support. And we're trying to work towards helping them with their complex issues to get the services that are needed, and help them understand and convince them that these services might help them remain as independently as possible for as long as possible. We are also working on a communication strategy. As I'm sure you all are aware, everyone knows what CPS is in Kentucky, but most people have no idea that APS is even an option for them. And so we are currently working with Barry Dunn to work on a more full communication strategy to meet people where they're at, to help them understand that these are options that they have available, to try to get those extra support so that way they don't end up experiencing maltreatment or end up in a living situation that they really don't want to be in. And lastly, focusing on the prevention. And moving more upstream and understanding that sometimes people are giving you hints that things aren't going the way that they want them to go. And so they just need to be able to reach out to us and ask for help. And so that's what our general adult services is designed for, is to get to people before it gets out of control. So that way we can get them linked with the services to help maintain their health and welfare. It's up to you.
Okay, so the collaboration between Guardianship and APS. So we work collaboratively. Many of our cases, but not all, come from APS. There actually is a decline in cases that come from APS. They are the second referral sources to Guardianship. The first is family. The majority of our cases do come from family referrals. So we refer to each other. APS refers to Guardianship, and then when we have individuals that we feel need additional assistance or victims of abuse, neglect, or exploitation, we make referrals for APS for them to investigate those. And we also have some planning between our staff and both of our staff in different meetings and discussing these individuals. We work collaboratively with community partners to aid vulnerable adults in the community and to help restore rights. APS and Guardianship support the work of CPS, so we both are at the table for these youth that are aging out to assist to see what the next level is needed, whether that be guardianship or just supports as adults. And we also have increased opportunities for training and professional development between the two groups. And that is our presentation. Any questions?
All right, I think we have several coming in the queue. Representative Callaway.
Thank you, Madam Chair. Thank you for your presentation today. It was very informative and concise. So what are the top 2 or 3 reasons that a case is substantiated? So, and I'd like to know more about the assessments, what those look like in each of the individual cases. That's one. May I be indulged for one more? My second is I'd like to know, you said that a majority of the cases are found in family environments. Are you seeing nursing homes? They've got kind of a bad rap recently. And how are those cases handled differently than family? Thank you.
So to the first question, the substantiated is just we make that finding if there is a preponderance of evidence. There's not really a reasons why I can say specific reasons why we would substantiate over anything else. We just gather as much information as possible through witnesses or evidence, pictures, things like that to make that finding. We do investigations into nursing homes. We try to coordinate those with the Inspector General's office to help out because we are not medical professionals, and so we need that assistance with the medical piece of it. I don't have specific numbers about the changes in the number of referrals that we've received at nursing homes, so I can't answer that specifically.
So you don't consider those separate, I'm sorry, okay. So you don't consider going to visit a nursing home if you have multiple complaints in a nursing home? Is that handled then by somebody else? Or if a family has an accusation against a nursing home? And then again, I would say then how are you justifying moving to guardianship or whatever the case may be, or even pursuing, some type of legal avenue?
Sure. So those investigations are completed the same as anywhere else. We have more specific guidelines on how to do the investigations, but we are investigating individual perpetrators, not agencies as a whole. That would be the Inspector General's office or the Attorney General's office to do that. And to the point of guardianship, just because we substantiate on someone doesn't mean we would go down the route of guardianship, because we are doing assessments. Every time we go out, we're assessing whether that individual has decisional capacity. And there are a lot of our cases where we come across people, they have all their decisional capacity intact and they are just experiencing some kind of maltreatment. So even in a nursing home, we would still focus the same way. Even if they're being abused or neglected, if they're lacking that decisional capacity, we would still enter and look for court action if necessary. But we don't typically pursue court action to get intervened for nursing homes, like against their staff. That would be something that the Attorney General's office or the Inspector General would pursue.
Thank you. Senator Mills.
Caught me off guard, Madam Chairman. No, I'm good. I was just leaning back. I almost fell. I apologize. I'm up here behind the column here. I'm about probably 2 months into visiting multiple times a personal care home in my community, and found that very intriguing to start with. The amount of money that they are required to do what they're required to do with. But I was caught off guard because one of the things they said was that through this process that they're owed thousands, if not hundreds of thousands of dollars from guardianships. And they complained of slow payment, excessive documentation and paperwork that was required. And it seems to me that if a person gets in a guardianship situation and, after a month or so, you would know what those repeated costs are. And why would personal care homes, I'm not saying they are, but why would they be put through the ringer by guardianship or by government to continue to document this over and over and over again? Can you talk about that situation and tell me if I'm off base? And then also I'd like to connect with somebody in your department to help me answer a few more questions and try to solve some things offline. But can you just comment on that? Is that a normal concern that you hear in your department?
So not so much normal, but it is a concern because, as I said earlier, we are utilizing and managing their money. Mm-hmm. So first we have to get access to their money, and it's not a quick process. So we have to apply for benefits on their behalf. If they already have Social Security benefits, then we have to apply to become the payee. And Social Security has a process for that. And just because we're appointed through the courts in Kentucky doesn't mean that Social Security agrees with the appointment of the guardian. So they first have to identify that we are the guardian. They have to agree with our appointment and make us payee. And that usually takes, if they already have Social Security, it takes about 90 days for us to get access to their money. Just imagine if you went into your neighbors, know nothing about them, and have to take over their life. It takes a long time to determine where are the individual's benefits, what kind of assets do they have, where do they bank at. You wouldn't know that, and that's kind of where we are. We don't know with these people at all, and at the point we're appointed, they usually can't tell us any of that information. So we're reliant on community partners, the facilities, whoever that referral source is, to tell us that information. So we have to send letters, send requests to banks, pensions, annuities, anything they have, and ask for them to, number one, honor the appointment of the guardian and conservator, and send us those funds. And it's not a quick process. So federally, it takes us about 6 months or more to get someone's VA benefits. Insurances, annuities, those kind of things, even longer. It takes a separate court order for that. So that is why there's a delay in us getting the money. And then those payments, that comes out of the individual's funds. So if they don't have the funds, then there's not money to pay those facilities. So that could be some of the delay, but I'm more than welcome to talk to you or connect you with our fiduciary branch if you have specific questions.
Thank you. Representative Rourks.
Thank you, Chair. In a previous meeting, I believe, when talking about APS, there was mention of some flexible funding that might be able to be used to bridge some of the services, and I'm thinking it might relate to the general adult services to try to keep people more independent so that they don't end up needing state guardianship. Can you talk about any of those kind of flexible dollars or things that we're getting creative with they being able to do to kind of mitigate folks from really having to enter the APS system in itself to kind of keep them more independent? Or, and if there is, what's working, is there any insight into ways that we could bolster or support more of that to provide some additional support?
Sure. So currently we use funds that were from ARPA funds that will expire this September, but we received Elder Justice Act grant funds, and it's approximately $170,000 a year that we use towards services for adults. So those services can be used at an investigative level or as a general adult services level, so that way anybody can access those. We use those for pest control, for individuals who need new furniture at their homes, they're moving, need first month's rent because of something that has happened. My favorite story is the one that one of the adults had given us a budget, and we had worked through a budget to purchase a used car with the funds to assist them because they couldn't get to their doctor's appointments, which was then harming their health. And it was more costly to take a taxi, and Medicaid wouldn't cover the cost of the transportation. So it was really kind of neat to see how well she did after that. And it ended up saving her money long term in the budget. But we intend to continue to do those supports. We have requested to buffer those to make sure that it stays a little bit higher than 170, because that doesn't go very far, especially when you're talking, even if you have to do pest control services, it is amazing how much of a different price it is depending on the part of the state that you're in. And so it can eat up those funds a little bit too quickly. And so we are mindful of that, and we are trying to make sure that we have enough to last the whole time in place. Mm-hmm.
Representative Dietz.
Thank you, Madam Chair. During the interim, I have been working on looking at the role of guardian ad litems in DNA cases, TPR cases, also guardianship cases. So you may not have the statistics with you here today, but I'm curious what you find the role of the guardian ad litem in these adult cases, beginning to end, and then if you know the fees that we've paid out on these guardianship cases, because I think the max is $500. I know for a lot of the counties, they'll have one person designated, and also are they actually meeting with the ward, since that's the word that we're still using. So I'm just curious of what you all see as the role of the guardian ad litem as I kind of move forward in looking at this statutorily.
So we don't really have any involvement in the appointment of counsel in the guardianship process, but I do use that phrase correctly, because in statute it should be appointment of counsel. So it's not specifically a guardian ad litem, and that's something that I do get questioned a lot, whether or not they're acting on the behalf of the individual or in their best interest. I personally see it as a lot of times it's the best interest of the individual and not necessarily what the individual wants. But that's how I see it currently in the guardianship cases that the state is appointed under.
And our only interaction is when we file that petition to have someone appointed as the guardian, is that a guardian ad litem is appointed by the court system. So I wouldn't have any specific numbers on that, because that's not something we usually track, and we don't necessarily work that closely with them because our reports go directly to the court, and the guardian ad litem would get those from the court.
Thank you. I believe Senator Carroll has a follow-up to that question.
Along those lines, with the guardian ad litem, in my district, there was a guardian ad litem that 31 count indictment dating back to 2006. And these were various acts of theft, misappropriation of funds, similar offenses related to those that were under his care. How does that happen, and who has oversight of that? And I knew this name 20 years ago when I was in law enforcement, and it took that many years before there was any movement on that. How does that happen?
So he actually was, or that individual was actually appointed as guardian, not guardian ad litem. So he was the actual court-appointed legal guardian. And so I can't say how that happened. I will say statute requires every guardian to file an annual report of the individual, so that they're personal, how they're doing, are they better, worse, if they still need guardianship, and then biannually they're required to file a financial report to the court. And the court reviews that and sends a notice on whether or not it's approved or not. And if they do not agree with the financial report, they send a notice asking you to come into court to answer to that. So I know from the state's perspective, we file both of those with the court when they're due. And, there's occasions that the court has questions, and then there's occasions that our accounting is sufficient and they do not. But ours is we have a very detailed accounting that we provide to the courts.
So the court would be the primary oversight of if there were something going wrong to act on that?
Yes. Every one of the 120 counties, the judges that oversee that case, they are the ones that review those reports, and they answer to the court directly. Okay. And if the person moves, then that case is transferred usually to the court where that individual resides.
Okay, thank you.
All right, we've got 2 more questions. We're going to wrap up for our last presentation. Representative Duvall.
Thank you for the presentation. That's been very helpful. Appreciate that. What is the goal or best practice standard for a caseload for guardian workers?
According to the National Guardianship Association, it's around 20. I'll just be quite honest with you. I've been in the role of guardianship for almost 21 years. I started my state career in it. And during that time, my caseloads, when I first started, were over 100. I had about 120. So we've progressively reduced those caseloads, and our goal is 45. I hope at one time, when I'm still with the state, that we get to 20, but that would probably take doubling our staff to get there. And it's definitely a lofty goal.
All right, thank you.
Okay, Senator Funke Fromeyer.
Thank you, Madam Chair. So how has some of the financial supports around kinship care helped to reduce the number of people that are perhaps guardians of the state?
Our individuals do not receive kinship care because they are 18 or older, so I can't answer that question on how that funding may have prevented them to come under guardianship.
Okay, thank you.
You're welcome.
Okay, I'm going to ask one last question, and then we're going to move on. I do appreciate the presentation. This is the first time, in my knowledge, this has been in the committee, so thank you all. I think, when we talk about families and children, I know I focus a lot on children, but the entire family is very important. And so I'm looking at the APS initiatives, and it says prevention for upstream, but Representative Callaway had asked about some examples of things that would cause a substantiation. And so I think I'm confused of if you really can't give examples of things that would cause substantiation in a case, but you're working on prevention. So I get, because I'm thinking, we work a lot with CPS, and so I'm thinking, okay, well, is it self-neglect? Is it physical abuse? Is it emotional abuse? Is it family neglect? Is it financial? I think that's one of my questions is, like, out of those, is there a specific trend that you all see that happens a lot with guardianship or adult protective services? So when you're doing that prevention, you actually know what you're working towards.
Sure. So the prevention efforts, because 41% of our cases are self-neglect, and so we find that the substantiation would be is that someone is neglecting themselves and it's impacting their health and welfare. And so our goal is to be able to get out there and start recognizing that there are individuals who have maybe some kind of medical issue going on and they need support, but they don't know that they can reach out to us to help them be connected with other support. So like home and community-based waiver, to get somebody to come into their home to help keep it clean, maybe not reach that level of hoarding that causes their health and welfare to decline. And so that's really what we want to try to do, is get back out there and get people to understand that we can help step in before maltreatment even occurs. We may not be able to stop maltreatment from when it happens, the same as like with children, because some of these situations, if it's abuse, like someone we can assist them with getting the abuser out of the home, but it's hard to, other than talking to people and doing some education about some of the signs for that maltreatment ahead of time, which we do that now, but we really want to get into that focus of people reaching out to us and just being willing to ask for help, because a lot of people don't want to ask for help for anything. And so that's really what we want to do. Is we're not here to just investigate you. We're here to assess your needs and help you get your needs met and move away from that investigative mindset.
Thank you. I appreciate that. And, if you all notice that there is a uptick in a specific area of prevention that's needed, please let us know. We are partners. We do want to be helpful. And so if there's anything that comes up and you think, oh, we really need to look at this, there are preventive measures we can do, or there are measures we need to take, please don't hesitate to reach out to the committee. But thank you all for your presentation.
Thank you.
And our last on the agenda will be discussion on the annual report of the External Child Fatality and Near Fatality Review Panel. Mr. Harrison and Mr. Shannon. Please introduce yourself for the record, and then you can get started.
Good afternoon. My name is Ben Harrison. I'm the Lewis County Attorney and also chair of the Child Fatality and Near Fatality Review Panel.
I'm Steve Shannon. I serve on the panel. I'm the Executive Director of CARP Association of 12 of the 14 Community Mental Health Centers.
Good afternoon. Alicia Mahoney, Executive Advisor for the panel.
Well, thank you all for inviting us here today to share with you our report that's been issued. We may skip a slide or two along the way, but I wanted to first introduce what we do as a panel and then some trends that we're seeing that's in our report. The panel was created by statute in 2014 for the purpose of conducting comprehensive reviews of all child fatalities and near fatalities suspected to be the result of abuse or neglect. The panel was designed to be an independent body. It is administratively attached to the Justice and Public Safety Cabinet. It's made up of 22 experts as opposed to a citizen review process. Members are unpaid volunteers. The slide there shows all the members of the panel. We are thankful and proud to have Representative Heverin and Senator Carroll on our panel. We appreciate their input when they're there. The panel is required to meet quarterly. However, we've been meeting monthly, and that's due to higher caseload. So the process for the panel meetings is that the panel review cases from the Department for Community-Based Services and the Department for Public Health. It is important to note DCBS conducts their own investigation into the fatality or near fatality and determines whether to substantiate abuse or neglect. After that, the panel then conducts a retrospective review of these cases regardless of what DCBS finding is. Cases from the Department for Public Health are referred from the local child fatality review teams and the state sudden expected infant death team. These types of cases were either not reported to DCBS or were not accepted for investigation. The local teams consist of first responders and community partners who may have firsthand knowledge of the event or the family involved. In 2004, the panel reviewed 219 cases comprised of 70 fatalities and 149 near fatalities. 11 of those cases were referred from the Department for Public Health. As part of the review process, the panel obtains relevant information from a variety of sources, which may include autopsy reports, medical reports, law enforcement records, and court records. These things are presented to the panel from analysts at the Justice and Public Safety Cabinet. They do a great job reviewing all of these things. Can't say enough good things about the analysts there at the cabinet. Panel members then determine key factors such as the type of case, family characteristics, other qualifiers, and then make a final determination. All data is stored in the panel's data tool, which consists of 22 fields with over 200 data points. So that's what the analysts are working with, those 200 data points. So our annual report is published by February 1st of each year. The report is submitted to the Governor, the Secretary of the Cabinet for Health and Family Services, the Chief Justice of the Supreme Court, the Attorney General, and the Legislative Research Commission. The report consists of case reviews, findings, and recommendations for system and process improvements to prevent child fatalities and near fatalities. The panel is now required to identify which agency is responsible for implementing each recommendation and forward that recommendation in writing to the appropriate agency. The receiving agency then has 90 days upon receipt of the report to do two things. First, respond to the panel with a written notice of intent to implement the recommendation, an explanation of how the recommendation will be implemented, and an approximate time frame of implementation, or they respond to the panel with a written notice that the agency does not intend to implement the recommendation and a detailed explanation of why the recommendation cannot be implemented. So the panel's made 11 recommendations in our 2024 report, and so I want to discuss some of those today. However, I want to focus mainly on the trends. So from our 2024 report, it shows that since 2014, 75% of all cases reviewed by the panel were children aged 4 years or younger. The panel has continuously found children in this age group are at a higher risk for a fatal or near fatal event due to maltreatment. These findings are consistent with what we're seeing in the national data. Prevention efforts should continue to target families with young children in the home. So if you want to skip to the next one to go to trends, I want to start with overdose and ingestion categorization from fiscal year 2015 to 23. These cases, the overdose and ingestion cases, have remained among the most common types of cases that we're seeing on the panel. The overdose ingestion rates seen by the panel are a small subset of a larger problem. The data reviewed by the Kentucky Injury Prevention and Research Center continues to show that numbers of ingestions among younger children are much higher than the numbers seen on the panel. This next chart here shows from fiscal year 19 to fiscal year 23, these overdose and ingestion cases, as far as the numbers go. We're seeing a lot of fatal pediatric ingestions. The number of kids dying from overdose and ingestions has more than tripled in the last 5 years, as you can see there. And so it's important to know what types of substances are being ingested to cause these near fatal or fatalities. As shown here, more than half of all the cases reviewed by the panel involve an opiate exposure. Even more alarming, 93% of the opiate ingestions indicated the presence of fentanyl. When examining the fatal cases, fentanyl was detected in 80% of those cases. We continue to see an increasing rate of pediatric THC ingestions. A similar trend can be seen when comparing emergency department data. The American Academy of Pediatrics published a recent study demonstrating a consistent increase in pediatric edible cannabis exposures over the last 5 years with the potential for significant toxicity. You can see the numbers there have greatly increased as far as the cases go that the panel is reviewing. So the next trend we're seeing is the plan of safe care. The plan of safe care, just as an explanation as to what that is a federally mandated practice that is intended to address the needs of infants identified as being affected by or having withdrawal symptoms resulting from prenatal drug exposure. The goal is to ensure the health and safety of the infant, address the treatment needs of the parents, and support the family and caregivers. In fiscal year 23, the panel reviewed 46 cases in which the index child was exposed to substances prenatally. This represented 21.5% of all cases reviewed. Of the 46 substance-exposed infants, 12 presented with symptoms of withdrawal and were diagnosed with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. In the slide there, you can see that the number of SCI and NAS has almost doubled in the last 5 years among the cases reviewed by the panel. The children in panel cases were exposed to a variety of substances, as you can see there in the chart. Similar to the NAS reporting registry, most infants were prenatally exposed to multiple substances. Specifically, 52.2% of panel cases involved babies exposed to more than one substance at birth. So we're seeing a combination of things here. When all types of opioids are combined, it accounts for 50% of the panel cases. So if you want to go to the next one there, Alicia. This graph illustrates the 4 case characteristics found in all panel cases compared to the rates at which those factors are found in substance-exposed infant cases. Each characteristic occurs at a higher rate in SEI cases. It is important to note the identification of these risk factors is not to compile additional stigma on the parents, but to clearly demonstrate the multiple and complex barriers these families and children face. So the next trend I wanted to talk about is trend in firearm incidents. So there in fiscal year 2019 through fiscal year 2023, you can see the instances of firearm incidents. They has fluctuated. 5-year trends in panel firearm cases document a decline in the number of firearm injuries post-COVID. While we think that's a very good thing, the panels have reviewed 79 firearm incidents in the last 5 years, which is a small subset of the overall pediatric firearm injuries in Kentucky. In fiscal year 23, the panel reviewed 12 cases involving injuries by firearms. All but one resulted in a death. 58% of all firearm cases involved a handgun, and a handgun we found was used in every child suicide case reviewed by the panel. And the panel has identified 75% of these cases were noted to be potentially preventable. So trend on youth suicides. You can see there the graph that it's similar to the firearm deaths there, kind of fluctuates. The panel reviewed 10 cases of youth suicides last year. 7 involved a fatality and 3 resulted in a near fatality. And when we examine the data from the Department for Public Health, the number of children dying by suicide are 2 to 3 times higher than the number of cases that are reviewed by the panel. We still try to seek out more information as to why these suicides are occurring, and so we're still trying to get more information as it relates to youth suicides. On educational needs or educational issues, you may ask, what are the educational issues that you're seeing there? And that is on the next slide, but briefly, the top 3 are truancy, IEP, and disciplinary issues. The previous slide showed that educational issues have drastically increased compared to previous years. The drivers behind the change in educational issues are not yet fully understood, but we've become more intentional about identifying those needs and talking about those things in our panel meetings. In this slide, you can see that truancy is by far the biggest issue that we're seeing. It occurs at more than 2 to 3 times the rate of the other issues. When examining suicide cases, 80% of those children had an educational issue. Children with mental health issues and medically fragile children also had higher rates of educational issues at 42%. These children are often enrolled in some type of virtual school. So I will stop there. That was kind of the trends that we've seen. I know that was quick and a lot of data, but we'll ready for some questions if you are, Representative.
Thank you. Thank you for your work on this, especially Alicia. Thank you for keeping it coordinated every month. I greatly appreciate that. This is one of the most heartbreaking committees I've ever been a part of, and it really is difficult to hear about. And so, I think being on the panel has really helped me as a legislator and as a chairwoman, because as we're looking at child welfare laws, I know to include a better eye on 4-year-olds and under because of the higher risk. I think that's also because they're not in school. They're not school age, so you don't have eyes on somebody. And so that's a big conversation, but we know that we've got to have more time sensitive on little ones. So I appreciate the conversation and the trends that you all shared. Representative Rorks.
Thank you, Chair. Would you allow me to ask 2 questions?
Yes.
Thank you. My first question has to do with educational issues on page 12. of our packet. I don't know if that correlates with the slide. But wanted to ask about IEPs and the lack of support for 504 plan. Could you tell us a little bit more about how those issues, what that looks like, and kind of how they've been highlighted here in the report?
Yeah, Steve Shannon, I'll answer that. It's really looking at if they have an IEP. So are they a special education student? We're not looking at the IEP contributes to it. It's just this is another way to identify a population. And 504 is similar to an individual education plan, but it doesn't have really specific educational objectives. It's access to services. It's just a way to get more data on who is being impacted in the school system and define that population more specifically.
Okay, thank you for that clarification. And then my second question had to do with the youth suicides and preventable deaths with firearms. Would more data around teens that have been shot or actually do die due to gunshots, would having a more thorough, comprehensive look at all of those cases be able to yield us better data and recommendations for what we could be doing to kind of curb those trends that we're seeing? Or do you think that the recommendations around safer storage and locks is kind of where we're headed at this moment in time? And then I also guess another policy question is, how do Kentucky's laws stack up with parental accountability in these situations?
What we really look at is a small subset, obviously, of those cases. And from my, I've been on it long enough that I probably didn't have gray hair when I started. It's clearly cases of, my opinion, the adult who has the gun has a cavalier attitude to the gun in the home. Many cases, one case I remember succinctly, well, I put the gun behind the TV like I do every night. Again, I don't own a gun, but it doesn't seem that's where you would store your TV, your gun. So I think there's that piece, and I think that's part of the plan of safe care. If you have one at home, how do you make sure that it is secure and it is put away? And kids, we had a case just last week, a 3-year-old shot his 2-year-old. Well, the gun was in the nightstand. He went and got it. How do you make sure those things take place? That's the big case. We don't have the data of others beyond what we get reported through DCBS, Department of Public Health, on those cases. But what I've learned is if you have a gun, and you can have a gun, there's no debate about that, be responsible. As most things, I have a driver's license. I should be responsible when I drive, and it's the same thing. I think that will really address that issue, and that's why the safe storage is such a high priority. We really think that can impact what takes place.
As far as comparison with other states' laws, that's not anything the panel has looked at as far as gun near fatalities or fatalities, but that is something certainly that is relevant and something that maybe we could look into.
Senator Mays-Bledsoe.
Thank you, Chair, and thank you for your presentation. I agree with Chairman. This is some of the most hopeful information in this committee and some of the most, it's hard not to cry sometimes.
I would have preferred to gone first. You could have finished with the first people.
Finish on the positive. I just had a quick, maybe more in-depth question on the educational side and the suicides. Did you break any of that down by age? Like, for instance, do you see a higher, you do, just didn't put it in the material. Could you share that or what you've learned if there's trends?
Sure, we could provide that to you. But yeah, we have several data points we can get you concerning that.
Okay,
certainly.
Thank you.
Mm-hmm.
Thank you, Chair.
Representative Stalker.
Thank you so much. The senator just asked a question that was smack dab in the middle of what I was going to ask, but if you know this off the top of your head, and I understand that you may not, but I'm curious about the educational issues when it comes to the truancy. I was wondering ages across the board for all of these particular issues, but can you guys speak to the truancy specifically? And if not, I'd be happy to follow up with you offline to get that information.
Yeah, we're going to have to follow up with you on that. We don't have that in front of you.
Yep.
If we had all the data points with you, I don't know that it would probably cover multiple desks.
Yep.
I have a lot of data.
We do.
Understood. Yeah, I would really appreciate that breakdown by age as well. Thank you so much.
Yes.
Representative Mosher.
Thank you, Madam Chair. Thank you for this information. We had a pretty good discussion just last week on suicide prevention, intervention, postvention, and I'm interested in how we can help. So I know that data is shared or data is collected in instances of suicide or suspected suicide by, of course, the coroner. I think Vital Statistics, I think KIPRIC also participates. Do we have a central database for this information? And if so, where is it, I guess? If not, what can we do about that? Do we have data sharing agreement issues? And I mean, where are we going with these recommendations? Who do you talk to?
I know KIPRIC has a lot of data. Public Health has data. Department of Behavioral Health. They testified last week. He's just a crackerjack guy back Whipple. He really gets it. They have data. I don't know the extent of what it's combined, how it's aggregated and what is that looked at. I think that's clearly the first step. I think important what we do is retrospective. And I remind myself, we got to take retrospective data and get the proactive policy and use that to drive it. And I think that is a real question. What is the extent of suicide? What are the different, it's mostly what we hear is guns, but it's not always guns. We've had some kids who have hung themselves, and I think those are really concerning. So I think it's just those information. And the more we can talk about, and I'll tout on the CMHCs, 988. All 14 mental health centers in Kentucky answer 988. You call 988, there's a 90% chance a Kentuckian answers your call within 21 seconds. We got to do that stuff. We got to tell people that, right? And we got to make sure people use it and take advantage of it, as opposed to, I see it, I don't do it, right? We need to make sure it's okay to talk about those things, and go on from, last month was Mental Health Month. It's a great thing. We have to talk about it on a regular basis. Talk about it. What does that mean? So I think that's part of it, and that's a stigma issue, but let's just figure out what it is and move forward. It's been concerning for a very long time, when the suicide numbers go up. We've gotten to a better place where I think we're reporting it as suicide. There's many times it was not reported as suicide because we didn't want to have that stigma of suicide. So I think it's the more data we can get, the more understanding of what happens. It could become better, and that's part of what this does for a subset of the population.
Right. May I ask one follow-up, please? Thank you. On the reporting, you just reminded me that I had a conversation yesterday with my local health department about this, about death certificates and what goes on the death certificates and the consistency of reporting on death certificates. Have you seen that as an issue that anyone needs to kind of drill down on?
I don't know specifically about death certificates. I will say a lot of our panel cases are seeing inconsistent practices among coroners. Yeah. So I would say that's probably part and parcel of the death certificate.
Right. Okay. Thank you.
Good question.
Senator Herron.
Thank you, Woman Chair, and thank you all for your presentation. A lot of my thoughts and questions have been answered, but I do want to bring us back to page 7, where it lists the case characteristics of these cases. I think that as we're moving forward, and I thank you, Representative Moser. We talk about data and what we need to do and how do we look at that data and how we allow that to inform us. But I think that what is interesting, I think it's another slide. It says plan of care, co-occurring. It's the bar graph. But I think that what's interesting with that bar graph, if you look, that very bottom line is financial issues. And so when we talk about the root causes of what is happening to our folks in our communities, to me, it's just very alarming that it's financial issues, then criminal history, which typically, if people have financial issues, they get into criminal behavior. And then that leads to the mental health, the trauma, and then the domestic violence. And so I just hope that as we are moving forward as a committee, not only just this committee, but in all of the committees that we have, that we're really digging down and understanding the root causes of the things that we're seeing across the Commonwealth. And I think that, for me, if we really want to create policy that is going to improve the lives of all Kentuckians, one of the things that we need to do is look at the financial issues. We still have one of the lowest minimum wages. We don't have living wages. So obviously that then goes into housing issues. And so it's like this huge domino effect. And I just, the work that I've done over the years with youth and families, it's something that I know. And I just want to bring that to us to say, when we're talking about creating whatever policy it is, not just in this community, to really look at all of these things together instead of just one subject matter. Thank you.
Here, Keturah. I love that you brought up the root. I think that's something that we always talk about, and I was looking at that as you all presented, and as we hear each case, and I think for you all on the committee, when we're on the fatality and your fatality review panel, we go through every single case, talking about what happened. Was it an accident? Was it not? Was it a drowning? It's horrific, and so I think that most of these have prior DCBS cases and issues that are going on. So what can we do to prevention? And I think that's one of the things that we sometimes miss is what are we doing for preventative services? So thank you for bringing that up, Keturah. We've got 3 more questions and then we've got to end because I know that Moab starts shortly and I'm going to have to get another water break before that. So Senator Meredith.
Thank you, Madam Chair. And this is an issue that we've discussed many times over the past 6-7 years. I remember specifically 5 years ago, we had 3 medical physicians from UK present some data on this very subject. The theme being that the alarming increase in suicide over the last 10 years. And I asked a question that really wasn't a leading question. I was sincere in my interest. So with the data that you have available, is there any socioeconomic group that has a higher probability of suicide than others that we can look at? Is it more with the race, income levels, whatever? And the physician that answered the question said, no, it's pretty much standard across the board. He said, except, and this is when he really started to struggle with his answer, he said there's a small group of and he's talking about teenagers. Teenager has to have a lower probability of suicide. He said that's a group that has some degree, and here's where he really struggled, has some degree of religiosity. And we saw if that is statistically relevant, in every committee meeting that I attend anymore, we talk about we need more data. But if we don't act on the data that we already have available to us, then what good does it do to have the data? But again, I asked a question, it's almost, I guess, rhetorical. If that statement is statistically relevant, why don't we talk about that more? Suicide, whether it's teenagers or young children or even adults. Henry David Thoreau said the mass of men lead lives of quiet desperation. I think it goes to what Senator Herron said earlier. If you can't meet your basic needs in life, then you're going to have a very desperate life. But again, if part of that solution is having some degree of religiosity, shouldn't we talk about that more? You see, it may be a rhetorical question, but thank you, Madam Chair.
I'm okay with the topic, but I think it's really hard. It's really hard to get to that place. I think it's challenging. We're trying to figure out what can we do, and really, who can we identify to stop things. So that's really our objective.
Thank you. And as we know with suicide, you can't ask somebody why.
That's why the recommendation for a psychological autopsy is so significant, to go back and look at that as you would a medical autopsy. What happened? What did we learn from that? And there's very few psychologists who can do that, partially because no one pays for that. If you paid for that, people become certified and do that. So I think that's one of the recommendations that will help address that question.
All right, Representative Wilson.
Yes, I just have a very quick question on the substances ingested. Maybe I just didn't understand what was like illegal substances versus like a valid prescription. I thought maybe the opiates meant it was a prescription, but then it includes fentanyl, which are you able to say how much is a prescription versus just illegal drugs?
I think that's a great question, and the answer is no. And even that, if you look at some of these, Suboxone is clearly a medication for people with substance disorder. Do they have a prescription? Are they taking it as prescribed, or do they get it some other way? So we don't know that. We have not pursued that level of detail, but I think there's a lot of things out there. At least it's a decent question. I think the THC issue is going to probably increase, as it's a very good thing. It's well regulated, but folks will figure out how to access prescriptions for chewables. So I think that's, and we don't know really how to differentiate if it was taken correctly, right person, right medication, right time. We don't
I was
know
just
that.
curious if it's like a storage issue for prescriptions.
Well, that's part
or-
of the plan of safe care, is make sure. And there's many times that it's, number of toddlers who take one of these and no one knows how they got it. Well, I had toddlers. We didn't have it in our house. That was our approach. So,
Alicia,
Thank
do you want to add to that?
Last question, Senator Carroll.
Thank you, Madam Chair. On the ingestion cases, I know we had talked some about enforcement on some of these cases and the lack of statutorial guidance, I guess, that is clear. And this would be more for illegal substances. And I remember we talked about that there's really no consistency across the state within law enforcement on how they address these. You might have a kid that a fatal ingestion, and they may not even get a test from the caregiver that's there. So, it seems like we talked about another state, maybe Indiana, that had a statute. So that's one that is on my list for the session to maybe address that, because these numbers are, it's alarming the way that they're growing, and there does not seem to be any accountability for those who are responsible for those kids in these cases. And there aren't, in a lot of cases, there aren't being thorough investigations conducted. So I think that's another area that we need to look at in that. And I will, just one comment, that what we said in the beginning, what you all said in the beginning, about 75% of the kids being 4 or under, we're spending a lot of time talking about universal pre-K these days. And that conversation is political. If we want to do something, let's do it for all of the kids, and let's fix childcare completely. Last week, within our facility, 3 different reports to DCBS. What are we preventing by reporting those things?
Mm-hmm.
What else could we prevent? What else could all the other centers throughout this state prevent if more kids were within their facilities? Food for thought. Thank you, Madam Chair.
Thank you, Co-Chair Carroll. I agree with childcare. Thank you all very much.
One thing real quick.
Yeah.
And I say this regularly. I think the frontline DCBS caseworker is the hardest job in state government. It's the most challenging. And I'll stack it against anybody. And we spend time trying not to be overly critical of the work they do, because the work they do is invaluable. And quite often, they don't get recognized for that. They enter really bad places, and they, at times, take kids out of their home. What's going on, what's taking place, and sometimes waiting on law enforcement to come with them. They go by themselves. So we don't want to be bashing the DCBS caseworker. We just want to get the system better.
Thank you, Steve. I agree. They put their life on the line a lot to be able to help kiddos and make a difference. So thank you for that quick note. All right, we have regulations to go over really quickly before we end. If CHFS will please come to the table. All right, we have 3 regulations proposed. Does anyone have any questions? Okay, I've got a comment and question on specifically KAR 1360. The overall intent of this regulation is to increase the per diem rates for therapeutic foster care providers. who provide care and oversight for children in state custody with the highest and most complex care needs. One of the main reasons for the per diem increase is to help provide additional placement options for children staying in DCBS offices. While the intent of the administrative regulation is very much appreciated, the regulation shows that the current administration's ability to fund Senate Bill 151 from the 2024 session, which provided additional services and supports to Kentucky's relative and fictive caregivers. As we know, the governor signed that into law and later issued a letter stating that his administration could not implement it because of the lack of funding, which would cost around $18 to $20 million to implement. And so I guess, what is the intent of the regulation and why are these per diem increases necessary?
Yeah, excuse me. Well, as far as the intent, obviously, I think as Representative said,
I'm sorry. I need all of you to identify yourselves for the record.
I apologize. I jumped the gun on that. Hi, Wesley Duke. I'm General Counsel at the Cabinet for Health and Family Services.
Hi, I'm Melanie Taylor, Director in the Division of Protection and Permanency.
Right, there you go. Try that again.
At the Division of Protection.
There we go.
The Division of Protection and Permanency at DCBS.
And I'm Sarah Bryant. I'm a staff assistant with the department.
And back to the question, Madam Chairwoman. Well, the purpose of this regulation is like you said, is to increase the rates for the therapeutic foster care. I think the need for that level of care is well documented here in the Commonwealth, and we want to make sure we've got the most robust and strong provider community that we can find for our children, and it is, and we feel that that this rate is, one, necessary, two, was funded in the budget that we are currently under, and we are trying, like I said, to build that provider group and to make sure that we meet the needs of those kids that need the therapeutic foster care level.
Thank you. How much was it going to cost to implement the per diem?
I don't have the exact number, but we can get that for you at the conclusion of the meeting.
So I actually have it. So according to the Cabinet's fiscal impact statement, it's going to cost $5 million to implement the per diem increases in the state for the fiscal year 2025, which would be January to June, and then $10 million in state fiscal year 2026, which leads me to believe that the Cabinet ultimately has found $20 million within its existing budget to do the per diem increases. And so we note that the Cabinet stated that you all are relying on a line item budget, as you just said, Mr. Duke, for the funding increase. However, this line item only provides federal and restricted funds for foster care increases. How did the Cabinet identify general funds outside of the budget line item and it's relying upon for this increase?
Make sure I'm looking.
And then in the budget, it's actually on page 116 from House Bill 6 from 2024.
Yeah, and once again, I'm not the Cabinet Budget Director. I can definitely vouch for that, nor do I want to be. But I will say that it is our position that when we reviewed the line item, when we looked at the appropriations that were made, that we felt that the money had been included in the budget for this per diem increase.
So are the per diem increases before us today required by statute?
I do not think there is a specific statutory component to this. I think it is part of the budget, and once again, like I said, to shore up this level of care. But as far as a specific statutory requirement, I don't think that exists, but I will confirm that.
I do want to remind us all that the governor did sign Senate Bill 151 into statute, and I would hope that statutes that are passed and signed by the governor's office, that they would actually be implemented and funded should there be funds available. The regulation today is very important. I'm not going to find it deficient. We're going to move it forward because it supports our most difficult to place children in state custody and for us to move forward, which is important to me. I've just talked about the amount of kids out of their homes, and so that is something I've talked about for several years now. There's no other explanation for not implementing Senate Bill 151 other than it's just not a priority of the administration, I feel like. And so I continue to offer to welcome you all to the table to have this conversation for us to find the funding, because our kinship care kids, we know that they do better when they're placed with family. And that's the most important thing that we can do, is set kids up for success when they've already faced such trauma. And so I would just ask that you all continue to consider that as we move forward through this. At this point, we have when we've been reviewed these, we have referred the administrative regulations for review. If no members have any other questions, okay, Senator Carroll.
Thank you, Madam Chair. On the child care assistance reg, what is happening that has led to that? Are there fraudulent claims? Is it confirmations of employment that's reinitiated? Where are the issues there?
It's just lining it out to give for those large amounts to work with OIG. The department continues to work with agencies on the smaller ones with repayment plans, but it's just the larger amounts.
Like that have built up over time, or help me understand?
I'm not certain on the exact.
Sorry about that. Senator Carroll, yeah, so these are obviously OIG continues to work with all the provider community on the smaller amounts, and if there's billing errors, and if there's, once again, you and I have had conversations about, something that may look like fraud may be a rounding error. So we continue to work with that, but this gives us the avenue on the larger amounts that could potentially be fraudulent to have a way forward to investigate them and look at them.
Okay, understood. And you all may not know this, there's still struggles with CCAP for teachers within child care. That process had one yesterday that got declined because her first paycheck only showed she worked 20 hours. That's all that's required under the statute is 20 hours, but yet it was declined. And there are constant issues with spouse income, which really is irrelevant, but I understand federally you all have to keep the paperwork the same. But that is, that statute, that law, in giving presumptive eligibility for CCAP for the teachers was designed to get stability within staffing and create a higher workforce. There's a lot of frustration, and we've had people walk away because they can't, they're fighting the system. They're staying on the phone 2 or 3 hours in a day trying to get through, to get things resolved. So we have a lot of work to do to get that functioning properly.
I could not agree more, and we want to continue to focus on helping on those situations. But then, if you do have a bad actor, you can deal with them this way. But as far as the providers go, to focus on them and to help them with all we can.
Okay, thank you.
All right. If there are no further questions, the referred administrative regulations have been considered, reviewed by the committee. The next scheduled meeting for the Interim Joint Committee on Families and Children is July 30th, 2025 at 1 p.m. here in room 149 at the Annex. This meeting is adjourned.